All right, who would like to start it off? Either questions about what you heard yesterday, new questions. All right, here we go.
I may have asked this question last year to Dr. Scott, and I don't remember, but Claire has, her diagnosis was trisomy 1, and it wasn't until a few years ago when I found the group that whenever I talk about her having 1p36 deletion, that her doctor says, oh yeah. We actually, last year after the conference, we met another family, Bobby Boyd, that lives less than a mile from our house. But Claire's deletion, she has the very tip, the 36.33 deleted, and then the duplication from the other arm is 42.11, and that's reattached itself to the place where it's deleted. What does that mean? Is to have a duplication? I mean, is that, I don't hear much about duplications.
Let me just ask another one. So is that on both the tips of chromosome 1?
Yes.
Okay, so sometimes you can have combinations, and probably many of you actually have kids that have combinations of a deletion and a duplication. So one copy is missing on the tip of one chromosome, and maybe there's a duplication on another chromosome. Sometimes that can occur because there's been a switch in the DNA on a chromosome, and basically you end up with this combination of a deletion and a duplication. Sometimes that can happen on the same chromosome. Sometimes it can happen on 1p and then something else too. It has to do with how chromosomes are basically segregated or split apart when you make either an egg or a sperm. What exactly happened for her, I don't know. We could look at the report and see if we could figure it out. But you will probably find that there's probably a significant portion of the families here that have both a deletion and a duplication, a deletion on 1p and a duplication somewhere else. Because it's pretty common that happens.
Okay. Okay, thank you.
When they've looked at the deletion 1p36, what they've found, what we initially thought was that there was going to be a semi-consistent breakpoint and that it would be a simple deletion. When they looked carefully, what they found is that many of the kids have complex rearrangements where there are multiple breakpoints, and you'll have segments that are deleted, but there might be a part in between the two segments that stayed for some reason, or there are places where a part of the chromosome is inverted or duplicated that isn't visible if you look at the chromosomes, isn't detected if you use FISH analysis, but if you do fine mapping, you find that the kind of situation that you have is actually not uncommon. So.
All right, I'm going to apologize in advance for asking this question because I think all three of you casually avoided it yesterday very skillfully. But what I heard about cardiomyopathy yesterday is that early diagnosis is better, that clinical signs and symptoms in kids aren't always evident, that there are published cases of kids developing cardiomyopathy later, and that we don't know who exactly is most at risk or who's likely to present when. So obviously there's a lot of things we don't know. But there are a bunch of people in this room that are concerned about this issue. So given that, how often do you screen and when? I know there's no evidence or a really good, guideline, but it seems that we have three people who are quite expert, and therefore we could develop a consensus statement while you're all in the same room. So again, my apologies, but interested in what you have to say.
Yeah, I'll weigh in on the cardiac portion, and then I'll allow these guys that are smarter than me about the guidelines piece. But we're very conservative in our cardiac practice, and there's a very simple reason, is that I would think that is absolute travesty if there was something that was potentially diagnosable and treatable that we just allowed to progress. We know by definition that this population is predisposed to potential heart muscle disease, and like I told you yesterday, and I was sort of giving you a template for a potential cardiac guideline in my conclusion statements, is that an initial diagnosis should prompt a referral for an echocardiogram for structural heart disease evaluation, period, in my mind. And I would include electrocardiographic screening in that as well, so the rhythm piece, simply because if there is an underlying cardiomyopathy, there's underlying scar tissue, you may have some problems with the EKG. So those are two things. And those are readily accessible tests. This is not something that you have to fly to some remote place. You don't have to go to Boston or Houston or to Cincinnati or wherever the case may be to do something like that. You can do that anywhere. The real question is about how do you interpret the data, right? When we talk about cardiomyopathy, that's a different piece. I would argue that no one knows enough at this point to say there are certain genotypes that are going to predict cardiac phenotypes, that if we, in my opinion, there should be a thoughtful, probably at least annual or perhaps every other year echocardiographic screening to make sure there's no evidence of heart muscle function decline. When we talk about diseases that are relatively rare, in my opinion, part of how I've been able to collaborate with geneticists is that most of the time the cardiovascular phenotypes are poorly characterized. And that's just some of Dr. Scott's partners I worked with on different syndromic disease characterizing rare populations that have really had, the longer you follow patients, the better we get at dealing with respiratory care. We get better with epileptic management, those sorts of things. People live longer. It's likely that cardiovascular disease will have some impact on their longevity. And so for me, I would argue that annual screening is not an unreasonable thing to do to rule out development of dilated cardiomyopathy. And it's simply because, especially as children and adolescents, you still have somatic growth, right? Children are growing. Well, so is their heart. So how does that growth impact their heart? No one really knows those sorts of things. So we're very conservative in our approach simply because this is remember, there are some things we do in medicine that we can diagnose that we can't do anything about. Some people could argue economically there's no reason to do testing if you can't intervene. This is something we can intervene on. So I would argue that testing makes a whole lot of sense. The other piece is a little bit more of a conceptual piece, is that when we talk about diagnostics of disease, it depends on the tools that you use. And these guys can talk to you about genetic testing and how things have evolved over time. And it's sort of like if you look at something, if you look at a picture on a wall and you're 100 feet away, it looks a certain way. You get 50 feet away, you get 20 feet away, you get 10 feet away, you get right up close to it, it looks different every time, right? So it depends on the tool you use. It gives you an idea of sensitivity. How can you diagnose disease earlier? If we use fancier tests like MRIs, I can diagnose heart disease earlier. So when we talk about guidelines, I think you want to talk about things that are readily accessible, things like echocardiography. But when we talk about how do we really fine-tune long-term management from a cardiac perspective, that's when you talk about it, sort of centers of excellence where you use people that have sophistication in these sorts of diseases, that use the cutting-edge technologies and the cutting-edge treatment strategies to make sure that there's no problems long-term. So hope that gives you a little bit of insight there, Rob.
So I have a couple of comments. One of them is we have some previous experience, not with 1P36, but with some of the other conditions where we have recognized risk factors and we started off not knowing, which is where we are with heart disease. In this right now, we have some preliminary information that it's relatively common to have heart disease and that there are two types of heart disease, cardiomyopathy and structural abnormalities. And that's about all we can say with confidence at this point. So to take an example where I have 20 years of personal experience, there's a condition called neurofibromatosis, that one of the things that it has associated is a brain tumor. And we know that we knew 20 years ago that brain tumor was increased. And so we started a monitoring program. And it was quite controversial, with some people saying that's a complete waste of time and some people saying, oh, you guys aren't doing enough testing. We need to be even more aggressive than that, and a lot of discussion. Well, if we hadn't started to do something, we would still be in that same place. So what we did in Cincinnati was start doing annual imaging studies for this brain tumor. We found after 5 years that that was not a good use of resources, because if we did a first scan and it was normal, we never had a new, that particular tumor didn't show up later. So we were able to say, if you get a normal scan at this age, in that case it was age 2, that we can stop screening. But 20% of the kids had an abnormal scan. And what we found was that those kids, it wasn't automatic that they needed to go on chemotherapy, because as we looked back, most of the time that tumor didn't change. So we've been able to modify the screening program, but we had to do 2 things to get that started so that we would learn a cost-effective, easy for the families, but thorough enough monitoring program for their needs that we now have, that doesn't cause increased or excessive screening, but doesn't miss cases of this complication. And that those 2 things are, 1, start screening, and 2, keep records in a centralized place on enough patients that we can evaluate the screening program. Right now, we can do the start screening part. He just outlined what seems like a reasonable way to start screening. I hope that we'll be able to space it out more than annual, but we'll have to wait and see what we find. What we don't have right now is a mechanism for pooling data on a large number of patients. So if we had data from all of the people in this conference with 1P36, that would be enough that 10 years from now we could have updated our practices a couple of times and have some idea what we're finding and how often we need to do this screening.
I don't see any hands raised. Back in the corner, okay. This is a big room.
My question's not about my 1P36 child, but I have another one that has HSV-related cerebral palsy. And she has been put on a diet recently with a dramatic cut in her calories, and we've noticed she's getting severe bradycardia. Is that related?
It's a good question. It definitely could be. The other thing, when we see severe bradycardia, we would worry about endocrinopathy, so things like thyroid abnormalities, so that should also be screened. But there's no doubt extreme weight loss, nutritional deficiencies, vitamin deficiencies that may be going along with that can definitely contribute to bradycardia. Weight loss in general can cause bradycardia, so patients that we follow with bulimia, for example, can also develop pretty severe bradycardia. So I would rule out or other organic potential causes as a part of the evaluation.
I just have a question. I think my son has absence seizures, but he also has autism along with 1P36. We did the 20-minute EEG study because there's no way, they wanted to do the 3-day, but there's no way he would leave the leads on, and he's way too unruly. Do you think it's something I should really be worrying about? I do notice that his behavior is decreasing, his challenges are increasing. His personality feels like it's decreasing, like I'm losing him more into the autism or the 1P, I have no idea which. And I don't know how much of it's seizure related, but I don't know that I should be worried that much about it, because I don't know that absence seizures are something I should really be worrying about based on the presentation from yesterday. So I'd love to know your thoughts on that.
No one else is reaching for the microphone, so I guess I'll go for it. I would say you probably have to have this conversation with your neurologist. Probably is what you really need. There's no question that we see, though, that sometimes when kids do have seizures, I guess the first thing you would wonder is, are we sure that these are just absence seizures, or there's something more that's going on? That may be a little bit hard to figure out. But we have seen some kids where they have seizures, and the major problem with them advancing is the fact that they are seizing so often. And so part of it depends on maybe how often these are happening, how much they interfere with his ability to do regular things. But these are probably, again, things you'll have to discuss with a neurologist and then say, well, what would be the treatment and what are the disadvantages of being treated? Is there any side effects and such that you need to worry about? But it's a hard one, and at least I don't feel like I'm super qualified to give you the answer for that one.
So a couple of, I agree completely with what he said. The issue with seizures is when your brain has these surges of electrical activity, it's not collecting new data, it's not making connections between experiences, so you can't progress because your brain is not able to process. So if there's a treatment for that, even if the absence seizures in and of themselves are not harming physical health, they will harm developmental health. The other issue is if they are seizures, the intervention for that is almost always medications. If you want to change the pattern of the seizures and allow for better developmental progress. If it is not seizures, the interventions are usually more in the way of therapies, speech therapy, physical therapy, occupational therapy, and bonding activities that encourage interaction, getting down into the kid's space and face and getting them to look at you and interact with you in any way that you can. And there were some good examples of that given yesterday by the speech pathologists. Those things do make a difference. So earlier there was a comment of arguing whether or not we should do something when there's not a specific treatment. I submit to you that we should make a diagnosis, know what we're dealing with, and address it as best we can, whether or not there's a validated specific treatment, and particularly not holding out for a cure or a medicine, but just holding on to interactions that are done at home does make a difference in every disease that it's been studied for, which unfortunately at this point doesn't include 1p36.
One of the other things that we often discuss with families that becomes perhaps a little bit of a hardship, but is probably worthwhile, is that we are very worried about vision and hearing loss. And so for most of the kids that I see that have any kind of disability that would make it more difficult for them to learn, I ask parents to get screened every year for vision and hearing loss. And they're like, wow, that's a lot of screening. And I'm like, yeah, but when you think about it, and your child can't tell us if he can't see, or he can't tell us if he's not hearing well. I mean, that's hard enough for us adults, right? When we figure this out when we go to a ball game, we can't see the pitcher and stuff like that. For a little child, there's no other real way that they can give us this feedback. And you can imagine if you're living in a world where you really can't hear what's going on or see what's happening, the development just is stymied. And so you really do want to think about screening for those two simple things every year, just to make sure that you maximize your ability for development.
Hi, my daughter is 13 and she has an interstitial deletion, and she's really quite mildly affected in high functioning, and yet she has very challenging behavior. And I'm wondering if you have found any dietary changes that would be successful in improving that. I know some people eliminate all dairy or eliminate different things.
So there's no data on this condition, and there's very little data on most other conditions for which people are trying that kind of dietary manipulation. There's a guy, Richard Kelly, who lives in Baltimore. He's a biochemical geneticist. He has studied kids with a number of causes of hypotonia, including some chromosomal deletions, and found that many, he thinks most, I don't know that we have enough data to make that conclusion, but many of those groups of kids have mitochondrial dysfunction. And that doesn't mean they have a mitochondrial disease, and we could talk for a very long time about how to define that, but mitochondria process energy. And if you don't have enough energy, then you have a hard time processing things, all of the sensory input and things, and you get problems related to that. He thinks that a vitamin supplement that's made to optimize mitochondrial function has a positive impact on kids with various conditions that lead to hypotonia and behavioral problems. And on some of them, he's actually got enough data to support that. It would be, I think, worth thinking about and trying something like that, the vitamin cocktails that are targeting that, although we can't actually recommend that because there's no data, so we don't know if it will be an added expense with no benefit or if it might have some value.
So who would I contact to find what to give her? Like, I would try that.
I think anybody you contact is just going to be making stuff up. A dietitian could help you to make sure that it's balanced, and if you know a pediatric neurologist or a pediatric geneticist who deals with metabolic diseases, they will know sort of the general principles for that kind of thing.
Okay, thank you.
Yeah, just to follow up on that, one of the diseases that Rob's referring to is Barth syndrome, and there has been some progress with that. The good news about the supplements that we're talking about is that they're relatively benign. So there are things that you can buy, but there has to be some sort of prescription and someone who actually has oversight if you're going to use these sorts of things. The things that we're talking about oftentimes can be bought at GNC. The problem is that you don't know if you're getting the right dose. They haven't been FDA cleared. They're not actually prescribed. So if you're going to make that sort of an intervention, it's probably worth having someone like a geneticist, a neurologist, a nutritionist involved who actually understands what you're trying to target and maybe actually follow the progress over time. Those actually are helpful. Those are heart helpful supplements as well in many cases. So there is some advantage. The mitochondria that you're hearing about are the powerhouses of the cell. So you think about the most highly consuming energy organ in your body, it's going to be your heart. So mitochondrial dysfunction is very much tied with heart muscle function.
So my question is quite technical and may not be that applicable to 1p36, but my daughter was diagnosed with 1p36 shortly after birth. She had a translocation of the 13th chromosome, thought to knock off that little piece of the first and joined up with that. Years later, my husband had had pheochromocytoma as a child that was cancerous. Even though he had undergone all the testing, they've now found this SDGH or SBGH gene. So he's been diagnosed with pheochromocytoma paraganglioma syndrome type 4. And it turns out that my daughter also has this, and this is found in the 1p36 region of chromosomes. So my question is, because when they hit us with this, it was like, we didn't ask all the questions, is because my husband has this in his 1p36 region, did this make my daughter's 1p36 region kind of unstable, and that's why it kind of broke off and joined up with a 13, or is it completely unrelated? And I'm asking specifically because if we go on to have more children, does it mean if they carry this SDGBH gene found in 1p36 region, that the 1p36 region is unstable and the possibility of having a child with 1p36 is greater? We also have a healthy daughter, doesn't have 1p36, and does not have the pheochromocytoma paraganglioma syndrome type 4.
Okay, so a little bit complex. It's kind of a challenge for us geneticists because literally we have like thousands of syndromes that we're supposed to know, right? I'll just tell you how it really works. There's a few of them that we actually know so well that we can walk into a room and say, I know this child has this. And we can do that, we can see it, we know it, we're done. Then there's like the other 4,000 that we have to look up every time to make sure we actually are talking it correctly. And literally I've sat in meetings where a person said, is there a gene for this syndrome? And another person in the room said, not as of 2 weeks ago. Because things move that quickly.
I'll just change the batteries.
So anyway, going back to what you said, I would assume that the change in the cancerous syndrome is just a mutation, right? And so typically there are things that can make chromosomes less stable, if you want to think about that. They're usually not mutations. So a change in just the letter code will not make a piece more likely to break off or change. And if it was a switch so this is the more complex part. I'll just tell you, based on the history that you gave me, if your daughter has both, or daughter or son, has both a switch on chromosome 1 and chromosome 13, that is a translocation, and that translocation can be in two forms. It can be balanced, where a parent, for example, can carry a switch where there's no genetic material that's lost. It's just that a piece of one chromosome is not where it's supposed to be. Those individuals will typically be asymptomatic, no problems. But they're at high risk for having a child that could have a major chromosome problem. So this can happen either brand new in a child where they have an unbalanced translocation. That's usually a deletion and a duplication. And then we always make sure that we check parents and say, do the parents have a balanced switch in those same chromosomes? If a parent carries the balanced switch, they are at that high risk. If they don't, at least in their blood, then we say the risk is lower, but we will never tell anyone that the risk is 0. And the reason for that is because if you think about it, we can only probe so many things. So we can only probe blood, typically, but blood doesn't make oocytes and sperm. And so there can always be just a switch that happens just in an oocyte making ovary or a testes making sperm. And so there's always some risk. So you will never hear me ever say there's no risk that this will happen again. That would be the number one thing in my mind. So the question I would have would be, have you and your husband been tested for that translocation, and are one of you a carrier? Okay, so if it's a de novo, that means brand new change in the child, the risk is lower, but not 0. Would there be still an additional risk because of the change in the mutations in that cancerous gene? I would think not. I would think that would be unlikely, unless there's something I'm not thinking about.
I agree with him. It's unlikely. There are a couple of cancer predisposition things where it's a DNA repair defect. Those do have an increased risk for new mutations and for translocations. But this gene is not one of those, so it's not known to greatly increase mutations in other genes or in other parts of the genome. So I doubt that it would be an increased risk.
One thing just to say, though, you can see that this is pretty serious to us, right? I mean, it takes us some serious thought. And so when we talk to families about the chance that this will recur, or the chance for this to happen in a child, we sit down and we seriously think about these things. And so it'd be worthwhile if you say, well, I'd like to know if my son or daughter who doesn't have 1p36 might be at higher risk. This is a good question to ask your geneticist. And you sit down and you look at all the data, you make sure you've done all the right tests, and then you give an answer. And when we write these things down, we take them really seriously. And so I spend a whole lot of time training my trainees that you don't make a mistake on this. And I never assume anything. So I want to see the report, I want to see everything, and then I make a decision. And if they have one piece that I cannot physically see, I say I must see that before I write this down. So it becomes kind of an important thing because it makes a huge impact for you as a family, right? And if we make a mistake and we give you the wrong impression, we feel guilty for a really long time. And you also feel really ticked off at us. And so again, if you ever have a question, it'd be worthwhile to sit down and make sure everyone's really done every step correctly, and then you have the full information. And then we never tell anybody to have kids or not have kids or whatever. Our job is give the information, and then you have to make a good decision based on what you think is important for your family.
I was just asking because I know things do change very quickly, because my husband and I, before we even had children, we went and saw a geneticist, and at that point they hadn't discovered this gene for the pheochromocytoma, which is very, very rare, especially cancerous in children. Then we had Zoe. We went to geneticists, found out, we don't have this translocation, blah, blah, blah. Still didn't have this gene discovered for the pheo. So then we got pregnant with our second daughter, and then just shortly after she was born was when they had discovered this gene, tested him, he tested positive. So we are back and forth, but we haven't seen the geneticist in about 3 years. So I just wanted to make sure that mutation they haven't discovered it does make the chromosome unstable, I guess was my question.
And they have not. I have seen a family for the condition that your husband has recently, and I can tell you that there wasn't anything about chromosome instability when I looked that up. That was about 6 months ago, so things may change, but I doubt it.
That's kind of what our experience is.
This is an important thing. If lots of bad things happen in your family, you're going to be told, well, it's just luck, it's unfortunate. I had a family that came in that had 3 people with very rare disorders, and they were told it was just unlucky. We did the math and figured out that it was 1 in 15 billion chance that would happen, which means it might have happened one time in the history of the world. And I didn't buy that as the final answer, and so we dug a little bit deeper and found that there was something that we could identify that was a genetic predisposition for the problems that they had seen. Ask questions. Go back and ask questions when there are things that you need to know. And if your geneticist says, I don't do follow-up, then complain, because we want them to change so that they will do follow-up and do the homework so that you can get the information that you need. Now, in defense of geneticists who only do diagnostics, if you're the only geneticist for something like 2 million people, and I know a couple of people that's the situation they're in, getting people in is very difficult. But that doesn't mean you shouldn't still ask for the services. You need them. Ask for the input. When you have questions that are best answered by a specialist, request to see the specialist.
My question is heart-related. Jade is 3. She was diagnosed with LV non-compaction, coarctation, and PDA when she was 1 month old. She did had surgery for coarctation and PDA. And yesterday was the very first time that I heard about the blood clot on LV non-compactions. I have never heard of it, and now I'm terribly afraid of it. And I've always been afraid of that heart condition that she still has. Is it something that we could do about it?
Sure.
And should we keep worrying about the coarctation? Because at one point they also told me that it could grow up again. Or
Yeah, no, it's a great question. So I'll take the first part about the coarctation, and that comes back to this idea of never being cured. So just because if any of you or your children had a surgical intervention or a catheter-based intervention for a structural heart defect, and if your cardiologist said you never come back you never need to see me anymore, find another cardiologist, because that's incorrect. The lifetime surveillance for these sorts of things is absolutely critical. We can talk about genetic stuff, and people think that, I would argue that's not a static phenomenon. I think it's something you also need ongoing discussion with a geneticist, but I think cardiology is one of those things that really is dynamic. And you think about your child being the size they are now, well, they're going, he's going to grow, right? All the children are going to grow. The organs have to grow as well. And the question is the growth of the aorta going to be commensurate with the growth of the body, right? Is it going to be the same? Anytime you intervene on a vessel, so you cut out piece of the vessel or you augment the size of the vessel, it creates scar tissue. That scar tissue doesn't grow. So you have a fixed point on a tube that's trying to get bigger over time, right? So it depends on how much scar tissue comprises the circumference of the tube. And the risk is that piece won't grow, the rest of the tube will grow, and that could lead to a repeat stenosis in the future, so what's called recoarctation. That's not uncommon, especially as people get into their 40s and 50s and 60s. As people get older, fortunately, it can be treated usually with a stent, so meaning it's one of those things that if the tube is grown as big as it's going to, we can actually go in there with a metal scaffolding kind of a device and keep that area open indefinitely so you don't have to have another surgery. But the point is a simple one, is that repeat evaluation is absolutely critical. The other thing we know about people with coarctation that you should bring up with your cardiologist is that sometimes they can have vascular abnormalities in other areas of their body. So making sure that their carotids and the blood vessels that go to their heads are well perfused and of adequate caliber, okay? That's easily done with the screening test, either with ultrasound or with things like a CT scan or an MRI, okay? The cardiomyopathy piece is a little more complicated. So when we talk about, I'll tell you what we do in our practice. So we follow lots of people with non-compaction, truly probably more than any center that I know of on the face of the planet right now. We follow adults and kids. So I see people in their 80s that have non-compaction, and I see people that are neonates that have non-compaction. And it's a spectrum of disease. Kids that have LV non-compaction that have good squeeze, so we think that the heart squeeze is reasonable and adequate, and we have no other concerns about them, usually we'll watch them because we don't see this incidence of the clot and the flipping off very common to occur very commonly at all. In kids that have abnormal heart squeeze, it's a very simple intervention. We put them on an aspirin, and that helps to prevent blood clot formation down in those little crevices. For all of the adults that I manage that have non-compaction, everyone is at least on an aspirin. Some people would be on more aggressive therapy, meaning if they had ever had evidence of a stroke, and we talk about these blood clots going to the brain, that's an easy conceptualization, that's a stroke. Blood clots can go anywhere, right? So they can go to your kidneys, to your liver, to your toe, wherever the case may be. That is also essentially a stroke, but it's a stroke in a different area of the body. What we're talking about is ischemia and infarction of the tissue distal to that blood clot, right? So it just means something blocks a tube and everything distal to that tube isn't getting good blood flow and it dies off. That's what we're talking about with the stroke in the brain, but those things can happen in any organ system. If that's ever happened in one of the patients that I follow that has non-compaction, we would put them on blood thinning medication like Coumadin or warfarin, okay? Or something maybe even a little more powerful from an antiplatelet perspective. So the point about talking about the risk with LV and C, I think it's important that people understand this embolic disease, the stroke potential. But the two things I really want your doctors to pay attention to are the heart squeeze and if there's unusual heart rhythms, because those by far are the strongest predictors in kids of something bad happening, okay? But if, we do have families that come to us and say, I do worry about the potential for a blood clot. The treatment is nothing mind-boggling. It's truly just an aspirin, and it would be dose adjusted for how large your child is. Okay? Sure. Oh, I'm sorry. No, go ahead. The other thing that I think the point of these conferences, and I do a lot of these sort of conferences for different diseases, different syndromes. the point of having people here is that you can actually have access to folks. So if you have a cardiologist somewhere that isn't doing exactly what you think you want them to do, or they don't seem as up to date as you would like for them to be, there's nothing wrong with asking them about the things you've heard about here today and yesterday, or about advocating that they reach out to someone who knows more about XYZ and co-managing you or your child. And I think that's also true for the genetics piece and everything else. If there's something that doesn't make sense, you actually have met people that know a whole lot about this, right? Take advantage of that. Sorry, guys, I volunteered your services, but I mean, it's those sorts of things. That's the point of these kind of get-togethers, in my mind, at least. So.
One thing we would just always be cautious, and we always listen to each other's things, because we'll think about one thing. You would never, of course, put your child on an aspirin without a doctor telling you to do so, right? Because aspirin also has other side effects, and also it can give you specific risks for other problems. And so just whenever we're doing these things, you'll notice that we always say you would get a prescription from a doctor, or you would see a nutritionist, or you do something, because these are all interventions that are really interventions, and so they have sometimes risks that would be associated with them.
Anybody heard of Chiari malformations in relation to 1p36? I haven't really been able to find anything.
So a Chiari malformation has to do with the back kind of part of the brain, and it can have the piece of that part that helps to do motor can kind of slip down where it's not supposed to be. We have a database with a bunch of kids that have different deletions in 1p36, and we have the structural brain defects that have been described. Chiari malformations are on the list, but they're not super high. In fact, there's not a lot of structural brain defects that are super high. I don't know if there's a specific correlation to a part of 1p36, but I would say the numbers are relatively small. I mean, you could take an instant poll and see if anybody else has a Chiari malformation here. Anybody else have one? You want to raise your hand?
Raise your hand.
Oh, we got a couple. 1, 2, 3. Well, okay. So if you got 4 in among 40 families, maybe we ought to look at that a little bit more. That's probably actually more common than I would have ever I would have thought. Are you familiar with this?
I haven't seen a lot of Chiari malformation, but I presented a talk on 1p36 at a meeting last summer. And at the end of the talk, I was talking about all the speech problems and things. And there was a guy there who is a neurogeneticist. He studies brain malformations. And he stood up and said that he had been asked to review, and that he had found that 1p36 is very strongly associated with some what look like fairly minor brain malformations, and he thinks that is a key driver of the speech and feeding problems, specifically something called polymicrogyria. But we know that brain malformations are not uncommon in this. So we have a lot more to learn about the details of that. But just based on the number of people here, that's clearly more than we would expect if you did this in a random population of the same size.
So do these families who have the Chiari malformation also have hydrocephalus as a diagnosis? No.
It's ironic that she mentions Chiari, because that was going to be my question. By going to the optician every 6 months, sometimes 6 months to a year, she's the one that found it. My question being, they told us that even us as adults, normal functioning people, have Chiari. My question is, how often should I have my daughter screened for that? Because we also was one of the ones that she was cleared with her PDA, we don't need to come back. So I have some concerns now, obviously, about how often we need to have her screened for the Chiari to see how much it's changed, if there's any idea.
So we don't have any information on that. And actually, if you look at other conditions where there's a high risk for Chiari, the typical thing is to do screening at the time that the diagnosis is made and then follow the growth of the head. And in children, that's all you do. And unless the head is growing at an abnormal rate, you wouldn't necessarily re-screen for Chiari. We don't know that that's the right way to do it, but that is the current practice in at least many places, and probably would work fairly well. What happens with the Chiari is the back part of the brain is shifted down, and one of the effects that has is it blocks the circulation of the fluid that surrounds the brain. If that fluid ends up under pressure because it can't circulate and be reabsorbed at the rate that it's supposed to, that makes head growth change. Now that's going to be a little bit tricky to monitor for kids with 1p36 because they may not have a normal head growth rate to begin with. So bottom line is we don't know how often, and they can't tell us if they have headaches or other signs that their fluid is under pressure very effectively because communication is a limiting factor. So if you see a significant change in behavior, getting a brain imaging study to look for something like hydrocephalus or Chiari malformation would be a reasonable thing to do. I'm not going to comment on how often to do imaging studies in somebody who is still making progress the way they have on previous imaging studies.
I would just say that the polymicrogyria is something that we're particularly interested in from a find the gene kind of point of view. As far as we can tell, there may just be one gene that causes that. We'd like to find out what that would be, because it's a unique kind of malformation that is seen definitely in 1p36 higher. We know that there's kids that are deleted for that particular region where the gene sits, and only a portion of kids have that. But then again, there's a lot of kids who may not have had the kind of MRIs that would be required to see it. But anyway, that is a specific one that surely is related to 1p36 and would be of interest to us.
So my daughter does not have a Chiari, but she has a syrinx very severe throughout her entire spinal cord, and she's obviously had it since birth. It was diagnosed at age 3. She had a cord detethering done, even though her cord was not tethered, but they thought it would then free up the fluid. That did not work, so she had a shunt put in her head, and it worked for about 5 to 6 years. She's now 15 years old. But it worked for about 5 years in her head. It cleared up the spinal cord right away. Then it stopped working, did a revision. And so bottom line is now we've put one in the back, and it just will not clear up. It keeps getting clogged. The one in the head, the revision in the head did not work. Then the one in the back just keeps getting clogged. So we're at the point now where, again, hers is very severe, where it's almost her entire spinal cord. And, you know, they don't want to do surgery on her anymore. And I know this is a major medical issue, and I know that we don't want to keep opening her up and keep trying and trying and trying, but I want to try a couple more times. I don't know what the other answer is. We've been in a couple different states. And, you know, some neurologists or neurosurgeons are telling us that, oh, it doesn't bother the, people. And then I hear other ones that are like, this is a major issue, that, her extremities are numb, the pressure on her spinal cord, and that's why, she's not able to use her extremities. So now they're just wanting to just treat, like she has dystonia very bad, and they think it's associated with that, and it's just gotten really bad. But they want to kind of just not do anything about the syrinx anymore and just focus on the dystonia and treating the dystonia. So my question is, do you have any experience about the syrinx or any suggestions about that?
We all sitting here looking at each other, and this is neurosurgery. none of us probably have the experience you're really looking for, honestly. A syrinx of the length that you're describing, I have not seen that. But again, even if I had, I wouldn't know what to do besides send you to neurosurgery. And so this is a problem that probably is an important thing based on the description of the symptoms you're talking about. How you would attack that, though, I do not know.
I just wanted to let you know that my daughter also has a syrinx, and it runs the entire length of her spine except for, I think, like L3 to L5 for some reason. It's clear, so it's 2 different syrinxes. And we see one of the top neurosurgeons in the world, and what we were told is trying to kind of solve the syrinx is really, really complicated when it's this big, and it doesn't necessarily change anything. Now, I don't know your child's symptoms, if that is related to the syrinx or something else, but I know for my daughter, she is able to ambulate in a full support walker. She waves her arms about, et cetera, et cetera. So it seems to be asymptomatic. I don't know for sure because she's nonverbal and she has cardiac issues, so she often gets blue nail beds, and her hands and feet are always freezing cold. So is it related to the syrinx? Is it hard? Is it 1P36? I don't know. But, I don't know if it's any comfort to you, but for you to know that my daughter has that and, she is running around and whatever. And like I said, the top neurosurgeon told me when it's that big, basically he said, we'll just keep having to go in and poke holes and whatever, and it's just going to keep coming back, and there's not really anything you can do. But he told us that it will not impact kind of her long-term health because she doesn't have hydrocephaly with it. So I don't know if your child has hydrocephaly, but so I don't know. He's a really good neurosurgeon, and I'm sure if
So I had to step out for a emergency in the other room. Did we talk about autism at all? Well, let's go. All right. So to make sure I cover these questions, because my wife's driving back from Indy back here. So I wanted to talk a little bit about, Dr. Scott, you were talking about potentially some, on the brakes, some genes missing, and I guess we just had questions about autism. Our daughter Lily has a secondary diagnosis of autism, and so we're wondering a little bit about that gene, if there's any relevance to it. Is there any clinical relevance to devising a treatment? Should we try and test for the gene with Lily? That is, would it be beneficial if she had these genes, if she was missing it? I guess we're just curious on the linkage, if any, and I understand that we're really early in the studies and that kind of stuff.
So when we think about autism, it's kind of a different kind of thing. It's almost like saying, the best way I can explain this is we say, well, 1P36 deletion kids can have seizures, right? And no one says, well, whoa, my child has seizures and 1P36. The way I kind of sometimes think about this is autism's kind of like that. And we use it almost as a diagnosis, but it can also be a symptom if you want to think of some other disease. So for example, we work with other syndromes, and we say about 10% of the kids that have this will also be diagnosed with autism. And so when we think about autism genes, they are a cluster of different genes that give a predisposition to having these specific set of problems that we talk as autism. I imagine, again, if we took a poll in this room, how many of you have kids that have a diagnosis of autism as well as 1P36? And so you're not alone. And that would not be surprising. Do we look for other genes beyond 1P36? No, at least not in my mind. In my mind, I think 1P36, a certain portion of kids will be diagnosed with having autism. And that's because of the behaviors that they have and their interaction with other people. And so we would say there's nothing more to look for because your child has that specific extra diagnosis. Does that make sense? If you have a child that comes into my office with autism, one of the things that we would do is we would do a chromosome microarray, And one of the possibilities would be that you might find a 1p36 deletion. Or you might find some other deletions that also can be associated with autism. You then asked about treatments and such. Is that my right? Okay, yeah, make sure you get your wife's complete list. As far as like a treatment, like a medication kind of treatment for autism, that's really not something that we have. But we do have the therapies and such that kids go through that help them. And so again, it kind of goes back to what was said before about the importance of having the correct therapies and the correct interventions. But there would be no medication, for example, that I would suggest. And so I would say you're not looking at extra genetic testing nor a specific medication treatment for that. And instead, you're probably doing the same things that are actually super important for your child, which is having the therapies and such that that child needs.
Insurance. What I was saying is we were looking at ABA therapy, and my existing insurance doesn't cover it, but I'm switching to a new organization, and then they may cover it. And I think every child is so unique that there's probably no silver bullet, obviously, right? But and you get different opinions from different people that you talk to. Oh, this therapist thinks ABA would be great, where this other therapist thinks, well, it takes some personality out of them because they're so focused on task lists, things of that nature. But
so what we do know is that intensive therapies for communication skills and intensive therapies for motor skills do benefit kids with autism. We presume, but haven't proven, that the same thing is true for kids with 1p36. Autism is a functional description, so it's not a specific entity with a single cause. In fact, most kids with autism have multiple factors that contribute. The most recent estimate I have seen for the number of risk factors that leads to autism is something around 10 per child with autism. In the case of 1p36, probably there's over 100 genes in the regions that are commonly deleted, and those probably add up to enough genes that are highly expressed in the brain to equal 10 different risk factors just by having that deletion. So if we were able to get a really detailed evaluation of the sort of behavioral pattern in kids with 1p36, that might be a better diagnosis than autism. But since nobody has done that research yet, we don't have that description. We don't know enough about the brain function in these kids to target specifically for needs of 1p36. Using autism as a known diagnosis with known recommendations does make sense. I think that at some point in the future, autism will be so much of a catch-all basket diagnosis that the 1p36 diagnosis will be more useful, but we need to get some developmental pediatricians and behaviorists and neurologists to do large-scale, very detailed assessments of kids with 1p36 deletion, define how their brain works, what the patterns are, and then we can design specific interventions targeting those things. The speech study that we did over the last couple of days, we hope is going to be a preliminary step on that, but it's a very preliminary step. It's going to take a while to sort that stuff out.
So I'm an engineer, and excuse me if I come at this too pragmatically, but when I think about the diagnoses that our kids have, we understand that they're predisposed to certain manifestations related to the condition. Get that. We don't know if that's going to happen or not. So as I listen to the speeches about things like cardiomyopathy, for example, I ask the question to myself, now I ask it to you guys, as you've studied it longitudinally and things develop or change over time, do you have any kind of information that helps us understand, cardiomyopathy is just one example, but there could be many others. Do we have any kind of information that helps us understand what's going on outside of the diagnosis that could cause changes? For example, certain genes that are present or not, certain environmental factors that we may be able to control or not. Because I think one of the things that helps us become more comfortable is, if this is something that could happen to our child, what are the things that we might be able to affect from that? Or what are the things that, if this is gonna happen, we can start preparing for it. But I think just that diagnosis and the notion that it could change over time still has a bit of angst that it creates. So I'm just kind of understanding where the research, science, and the contribution of information from related areas might be going with that.
So there aren't any longitudinal studies on 1p36 at this point, so we have limited data. There are a few things that we can gather out of what has been done. There are some reports that look at, for example, basal metabolic rate, predisposition to obesity, and in the kids who are heavier than we would ideally want them to be, there are some reports indicating that insulin resistance and other complications of obesity are in fact part of that. That's potentially modifiable. So we have some preliminary indications. We have, over the last 3 or 4 years, some indications that the kids who are born with cardiomyopathy can progress, and that can be asymptomatic in childhood but be a major problem in adulthood, even a life-threatening problem. And you have heard from Dr. Jefferies that that's potentially a treatable issue. We know that hypothyroidism is increased, and hypothyroidism is easy to treat if we recognize it. So screening for hypothyroidism, to me, makes a lot of sense. Hearing loss is also something that might happen that has environmental components as well as genetic components, and that is very treatable in most cases. So that also makes sense to be screening for. There's a lot more work that needs to be done, but there are some things that are modifiable that we can track over time.
Right, I get that part. I guess my question is, that's a reactive situation where I test, I identify a situation or a condition, and then I react to it or I treat it. My question is more about being proactive. How do we get ahead of the fact that insulin resistance could occur, or, there's a lot of conditions that it sounds like are associated with cardiomyopathy. So if we captured information there to be able to say, environmentally, for instance, when these things exist, or when we were talking about seizures yesterday, if this mapping exists, then it could manifest in this way, so we need to think about the fact that it could happen. So I know that these things can be treated, but I think a lot of us would like to be able to be ahead of it and be able to say, if I'm feeding my kids Cheerios and it can create absence seizures, we need to understand that relationship so we can not feed them Cheerios and give them Frosted Flakes or something.
So the things that I was talking about, the idea would be to screen for, plot the growth chart every time the child goes in to see a doctor, and if you start seeing a trend toward unacceptable or undesirable weight gain, that you meet with a dietitian before they are at the point where you would see the insulin resistance and try to intervene for that. At this point, we don't have anything that's been validated, but we do have things that we should anticipate. We know that the kids most of them are going to have decreased physical activity, low muscle tone, difficulties with coordination. So how do we then increase caloric expenditure to get them to burn calories so that they don't end up being overweight? There are things we can do about that, and we need to think about those things now. What we don't have at this point is any records from people for what works and what doesn't work, or how much difference that makes in the long-term outcome. The how much difference does it make is by definition going to take a very long time to collect, because what we would have to do is identify kids at this age, pick some interventions that we want to try, and then see 15 years from now, are they doing better than the kids that didn't get that intervention?
Yeah, I hear you, but it still seems kind of insufficient. For instance, when Dr. Jefferies talked about the conditions related to cardiomyopathy, and Sophia's got one of them, one of the concerns that we had is the potential for clotting. So the question becomes something simple such as, if we know that clotting becomes a factor in this, should we get her more exercise to avoid the clotting? Because we didn't even know that existed. Am I making sense? Because
Absolutely.
I'm hearing you,
Absolutely.
but I'm not sure that it's really answering the question.
Yeah, I think I'll try and maybe expand a little bit on what Dr. Hopkin is saying. To get to this at a population-based level, we need registry data. So you need longitudinal follow-up data with a lot of people putting in robust phenotypic information that you go back and mine, right? But there's a difference. When we talk about things, I don't think patients always take this away, but we've had this discussion in clinic, and I do this very specifically. When we talk about populations, 10% are going to have autism. That's a cohort of patients. That's not the patient in front of me, right? That has to be individualized therapy. And I can talk about, well, the risk of developing XYZ is 67%. You know what the real risk is for your child? 0 or 100. You're either going to develop it or you're not. We're talking about a population when we talk about those sorts of numbers. So I think the first takeaway is when we talk about preventive, it's kind of a preventive strategy. If we anticipate something, has to be individualized to the patient in front of you. For a cardiac perspective, I'll only talk about that. We know that things like when people, and we may have had this conversation, but when people come to my clinic and I say you are predisposed to cardiac disease or you already have existence of cardiomyopathy, and they say, well, what else can I do? Well, the next thing is don't give yourself another risk factor. So for everyone in this room, if you came to see me as an adult cardiologist, what would I say? Don't smoke, don't drink in excess, don't develop diabetes, don't become obese, don't develop systemic hypertension. Things that are applicable to us, right? All of us, don't do those things. If there is any indication of insulin resistance, that leads to a thing called the metabolic syndrome, potentially. Obesity, triglyceride abnormalities, insulin resistance, moving towards diabetes. Diabetes, in and of itself, is the equivalent of having a blockage in your coronary artery from a risk perspective long term, just as an example. So I think what Dr. Hopkin is saying is that people, in a thoughtful way, can be screening for those, but it has to trigger some sort of a mechanism to say, maybe we need to be more aggressive about this, right? We have all kinds of data that come to us every time we see a patient in clinic, but what really matters is how does that data point fit in the context of all the other data points that we have, right? Okay, this has been happening from a growth perspective, and we see a divergence between weight and height on this visit. Does that mean that maybe we need to be thinking about some sort of a dietary intervention, an activity intervention, those sorts of things? So I don't want it to sound like a cop-out answer, but what I'm saying, at least from a cardiovascular perspective, are common sense interventions. We wouldn't want anybody to weigh 450 pounds. We don't want anyone to have a systolic blood pressure of 180 millimeters of mercury. We don't want anyone to develop diabetes. Recognizing that some of those things also have genetic predispositions, and you can't always fight that. You can't say, well, I'm never going to develop diabetes. You actually can't say that with complete confidence, but we would want to do everything we could to avoid that, right? And so I think from a proactive perspective from cardiovasculars, we would say, if you have known disease, we want to treat it optimally. If you're at risk for disease, we want to screen aggressively and treat if something presents. But we also want to take away anything that could potentially be modifiable. And those are things that you guys are already well aware of. You know, we could target specific things and say, well, I'm worried about someone developing a selenium deficiency. I want to make sure that doesn't happen. What I'm talking about is very global. In that if you did see evidence of weight gain in your doctor, and we deal with this with children with other genetic-based diseases that are inactive, and something like Duchenne would be a classic example of that. So muscular dystrophy patients, wheelchair-bound all the time. We have them on steroids, and so their weight goes up, up, up. The problem is with that, their blood pressure goes up, up, up. And for me, that's a problem because as a cardiologist, I know that that makes heart muscle function go down, down, down. So those are the things that when we talk about, I think Dr. Scott was right, is that, you have to think about it in the context of everything that you're managing, and that's the key when you manage children that have a complicated phenotypic presentation, is you need a care management team that is all on the same page, right? You could easily see a geneticist and they're thinking one thing, and if I don't know that, they're thinking, wow, I really should be watching the weight, and that may be an important thing, but I'm not aware of that. That sort of, I think, can limit the ability to deliver effective care. So more than anything, when we deal with comprehensive care, I think it's just a matter of making sure everyone's on the same page. And they're expressing those sorts of concerns to people, is that I want to do everything that I can for my child. And it's not those far-reaching sort of out there sort of interventions. What you asked is a very practical and absolutely pragmatic question, is that I want to be proactive and I don't want to react. That's exactly what I'm talking about for cardiac disease. I don't want to react. I don't want someone to come to me with end-stage heart failure. I want someone to come to me who says, I know that I'm at risk and I want you to pay attention to me and I want to catch me as early as possible. Those are the situations that universally do the best long term. So I think it's a great thought.
I don't want to sound cheeky or lame, but when I was listening to this conversation, I was thinking, don't let your child smoke. Make sure they get enough exercise, all this. I mean, really, that is the way that it works. You can also, it's worthwhile to listen to your pediatrician and also think about the things that they're requesting perhaps for your other children that don't have 1P36. I mean, something simple like your child, I don't know, just safety things. I mean, they're just really common sense kind of things. Almost all pediatrics is preventative. I mean, when you go to a pediatrician for a well child check, they check things, but basically their main purpose is to help you figure out what can you do to prevent stuff. And so all those simple things are really worthwhile in the long term, because again, you have a child who already has specific deficits and problems. You do not want to add to these things. And so, if you said, well, what would be the major intervention for a family where a parent smoked? I'd say the number one intervention to help your child would be stop smoking. And that would be, as a pediatrician, that would be my number one. And that would make a huge difference in that child's quality of life.
This is actually just for all those people who have the autism diagnosis. I have been on that journey for a couple of years, and I highly recommend looking into the Sunrise program run by the Autism Treatment Center of America. It's very different from ABA. It has improved my own life and my daughter's life tremendously for the better. 2.5 years ago when I started the program, she could not speak. Now she talks in 3 to 7 word sentences that most people can understand. She's learning to read, she's learning to write, she eats better, she is no longer constipated. It has helped me deal with the emotional component of the whole thing so much better, so that I can go into the room and do 2 hours one-on-one or 3 hours one-on-one, and I train volunteers. And it's not something that most doctors know exists or talk about. And it is mostly for people on the autism spectrum, but for any challenge, it teaches parents how to be a really strong advocate and get out from that emotional weighing down where you feel like you're under a ton of bricks, or you try something and it doesn't work and you go get the pint of Haagen-Dazs for yourself and you and your kid are both crying. So anyway, I would highly recommend it, and if anyone wants to talk to me more, I am always willing to talk and answer questions about it.
What's it called again?
The Sunrise program, it's spelled SONRISE, run by the Autism Treatment Center of America, and it was started in the 70s by Bears and Samaria Kaufman, whose son was so severely autistic they thought he was deaf, and he had no language, made no eye contact, was a complete limp rag when you picked him up, and they were told to put him in an institution, and instead they said no, and they started working with him one-on-one 12 hours a day for 3 years in a bathroom. When he would spin, they would spin things. When he would rock, they would rock. And after weeks of this, they got flickers of eye contact. So they never forced the eye contact. They would join him in his world until he was ready. And he completely 100% emerged and is the global director of the Autism Treatment Center of America now. And many other kids have been fully recovered.
I was just going to say, when the gentleman was talking about what can we do in advance, one thing with my daughter, of course, she's nonverbal, she's very complex, has a lot of issues, and I learned from you guys, my doctors around do not know, so part of catching things early is we know they're predisposed to liver and kidney disease and heart issues is we go every 6 months for a routine blood exam to catch it early. Hormone levels came up once, so they monitored her hormones for the next year to make sure that she wasn't having hormone fluctuations. So yes, there's not a genetic test to say definitively she's going to have this, but from this group here, we know that these are complications. So we do these annual panels of blood. I know it's not fun, but just to keep check on it every 6 months or every year, depending upon the test that we're doing. So that's all I was going to kind of say towards the heart issues and whatnot. So.
It's actually a very thoughtful comment. We talk about these organ systems like they exist in a silo, right? Well, if you have heart disease, or if your kidneys are abnormal, it doesn't affect your heart. Actually, people with primary liver involvement can have cardiac involvement. People with primary cardiac involvement can have kidney involvement. So it's not just about echoes. You actually have to be pretty thoughtful in what you're doing. It's absolutely on target.
I just had a follow-up comment to the Sunrise program and preventative measures, et cetera, et cetera. I know for the kids with the really low muscle tone, one thing that we've been told and we find very, very helpful is our kids love to roll around on the ground, and that's great, but also get them upright, especially if they have a lot of lung issues, because just being in that upright position is really helpful for their lung development and their cardiac development and all of that sort of thing. And the Sunrise program, I'm familiar with a little bit. We haven't done it, so I don't have any specific things to that. But I think one thing about that program is that it does meet the child at the level that they're at. And to remember that underneath the 1P36, I know this sounds really cheeky, but it's similar to what you said, they are just kids, And so remembering that, and that every symptom is not necessarily a symptom. It may just be how that child is and what they enjoy and that sort of thing. And sometimes I feel like we sometimes forget that, and it's almost like we're trying to take the 1P36 out of our child. But I mean, they are a child with 1P36 and they're just kids and that sort of thing. So definitely, obviously, behaviors that aren't safe and things like that. But we did find with Zoe, it was similar, it sounds like, to the Sunrise program, is meeting them at their level and then rewarding them for the little things, even just making eye contact and being like, oh, thank you so much for looking, and, that sort of thing. But I don't know. I guess that's my big thing, is that they are just kids, and let them have fun too. And if they want to chew on the toy, then I don't know. I just let my kids chew on toys. I know that's a big debate, right?
Not in my family.
My son was diagnosed at 5.5 months. Not had a seizure, no heart issues. I mean, his neurologist, we got hooked up with a neurologist a year and a half ago at Cook's at Children's in Dallas. They said that when he had an MRI that there was spots on his brain, but to come back every year just to make sure, hey, it's not affecting anything right now that they can tell, but just keep coming back to, in a year, that's fine. My thing is since he hasn't had any seizures and he seems to be part of the higher functioning, does that mean that he's never going to have any seizures, or is that possibility just he's going to have it just like we all eventually could end up with diabetes? It's just a matter of what he eats and the external factors that we have. Plus, we just started growth hormone shots, and I think I've seen a couple of different posts about kids starting growth hormone shots. We started in November, like the week before Thanksgiving. He was in 12 to 18 month clothes, and now he's almost growing out of 4T. That sort of has helped with his constipation and his diarrhea. I haven't been giving him Miralax. I haven't been giving him, that's just an as needed if he's super constipated, but some of the foods that he eats gets him to have diarrhea really quick, and that helps with the constipation issue.
So the seizure question is fairly straightforward. When we looked at older patients, we found some who had had their first seizures in late adolescence. So there isn't a time when you can say, he will not have seizures or she will not have seizures. We know that there's a predisposition for seizures, but the longer somebody goes without a seizure, the less likely it is that there's one coming. So, and that's true whether they've previously had seizures or not. The longer they go without a seizure, the less likely there is. Things like growth hormone, I think, are interesting. Growth hormone, one of its effects is to make kids get bigger, but that's not the only effect. It increases lean body mass, which is muscle and bone, and decreases fat deposition. It also changes the brain maturation. And for a couple of conditions, if you start it very early, it increases cognitive abilities a little bit. Now, does that mean that every child who has developmental delay should be on growth hormone? No. But it means that it could potentially be of benefit for some kids, even where growth isn't the primary concern. We can't recommend that. We can't. That's a case-by-case thing at this point, and it would require a formal clinical trial that was randomized with some kids who get treatment, other kids who don't, to really answer that on a population basis.
Because his endocrinologist, well, we switched from Cook's in Fort Worth to Children's in Dallas because the endocrinologist was like, well, we've had 2 bone age density tests and he's never going to grow, and I mean, if he does, it's going to be very, very slow, and he's going to either live with y'all or be institutionalized. And I'm like, yep, that's the last time we're going to go back and see him. But the one that put him on the growth hormone was like, well, we don't know how long it's going to be. We just increased it back in April, and he started it in November of last year. So I don't know how long he's going to be on it. And if anybody has their kids on growth hormone, how long are they still on it? 4 years on Norditropin? Okay. Okay. Yeah, because I mean, I said, how long is he going to be on this? They says, right now until further notice. I said, until further notice, because they don't know, because when they did it, his tests were so low that they said, okay, it's working, it's just not sending enough juice. It's like when you turn on a light and it starts to go very, very slow. That's basically how she described it to me. It's like the light switch and the light bulb, they know how to talk to each other, they know what to do. It's just they're working so slow and it's just not doing anything. And I says, okay, then that's something that I'm willing to do, is if it helps him and they think it helps him, I trust their judgment and they trust what I'm saying, But I just didn't know if there was anybody else out here that Yeah, he's started walking in March. His constipation issues have cleared up way much better than they were, this time last year for the conference. And if they say that it's good for him, I highly recommend it. I do know that it is a case-by-case situation, but I'm all for it. He started walking. He's starting to talk a lot more. He's strong before it, and now he's even more stronger. And I'm like, okay, I just put my kid on steroids. He's gonna kick me, and it's gonna be harder, but that's okay.
We were on it for 2 years. I really think it helped Colin walk, because the first, I would say, 9 months, nothing, absolutely nothing. And then they kept tweaking it, and then, we were supposed to be on it until the growth plate and all that. Giving him a shot every day was the worst experience of our life. He's now 8, he stopped 4 years ago, and he still every day says, no shots today, no shots today. He's really upset by it, but I think it was instrumental helping him get that next level, and I do think it helps him growth-wise and, make him acquire a lot of skills. Cognitive skills that I think I could never get him to understand why we were doing it, that by the end of 2 years, it took two of us sitting almost on him to give him the shot, and then we just made a family decision that it wasn't worth putting him through the shot. But I do really think your child will tolerate it. And it's medically necessary, I believe in it. But
Yeah.
it has to be medically necessary. It's a big undertaking, it's a big expense, it's a very big deal with a lot of consequences that everybody should look into and weigh the pros.
All right, thank y'all.
I have a really quick question for Dr. Jefferies. Is there any evidence that stem cells can help with the regeneration of the heart or repair of the heart?
Yeah, so I'll talk about stem cell just in the context of isolated heart muscle disease and not about anything else. But so stem cell therapy has been going on for over a decade, and it seems like it's a novel thing, right? You think, oh wow, this is the latest and greatest. It's actually been going out for a long, long time. And it hasn't, the reason it hasn't reached prime time, the reason we don't do studies in kids is that it hasn't been shown to be as effective as we thought that it would be. There are some patients get an improvement in symptoms. Some patients get a minor improvement in how the heart squeezes. But all in all, it hasn't really been the sort of panacea that we had hoped for. So right now, there are really no active studies looking at children independent of having 1P36 or anything else. Those would be, we really haven't shown what I would say is complete safety or efficacy in an adult population. And so for us to ever translate that into kids, I wouldn't be an advocate for that until we really know more about what the effects are going to be. Interestingly, you know, a lot of the medical therapies that we employ for kids with heart disease, take this away, we've talked a lot about comorbidities and whatnot, but think about heart disease in kids in a more positive way, is that most of the kids we deal with are completely different than the 65-year-old patient that I see with heart disease. That 65-year-old has smoked for 40 years, has diabetes, has high blood pressure, has had a stroke, all those sorts of things. Kids don't have those comorbidities. So the likelihood that they'll respond more favorably to cardiac medicines is usually higher, interestingly enough. And so we would say that medications are usually a good way to go. Stem cells is one of those things that's like step number 43 when we consider advanced care. And hopefully we would never have to talk about those sorts of things.
Hi. First of all, I want to say thank you very much for dedicating your time for our 1P children. And because I'm just reflecting on all the issues with our children. They are unique. And I'm a big picture person. And I'm looking down the road maybe for a 5-year plan. Would it be beneficial for us to marry up with another deletion syndrome to help us run like a clinical pathway for all our concerns with GI, cardiac, neuro, hearing, speech? It's kind of like a matrix that other deletion syndromes are going through, and maybe a bigger cohort of kids with, you know, we all seem to have similar issues but different, and maybe that will be helpful for us to navigate through some of these similar questions we're having. And how can we help with that? Maybe we can, what can we do to get our geneticists and or maybe our local cities to help marry up with you, since you seem to be the command control? I don't know.
So a couple of years ago, I actually talked to the 22q13 deletion support group and asked them for advice, and that I would then share with you guys. And you know, each of the syndromes is to some extent unique. So I don't know that the clinical trials, but you certainly could. Like your board could communicate with their board. And there are a number of other syndromes that have sort of overlapping needs and maybe have been organized a little longer or have already learned some things. So having that communication could be very useful. But from a clinical trials standpoint, unless we know that the pathway as far as the physiology, the function of the body on a cellular level is overlapping between the conditions. I think you're going to have to develop 1P36 sort of independently, but using their identified resources, the sort of organizational ability to get things to move forward is something that you could get from these other organizations. And particularly if they have, if you identify other conditions where they have seizures, hypotonia, heart problems, similar kinds of symptom patterns.
I would say you're allowed to do whatever you want to do. I work with a number of different organizations. One of the things I work with is a problem called diaphragmatic hernia. The difference there is that diaphragmatic hernia is very obvious as soon as the child is born, or most always is. And they're usually in critical care for a very, very long time. That particular organization has a benefit in that they can walk into a hospital and say, who has diaphragmatic hernia, and you can actually point to the kids in the hospital that have it, that have been newly diagnosed. You've made it obvious that there's a lot of kids who come into 1P36 at age 7, age 9, age 1, at birth, before birth. And so you have a much harder target in that people are entering this in many different times and ways. One of the things you do have power with, though, is that you have a lot of social media and presence on the internet and such. That's a big benefit. So I see people who constantly email me saying, my child was just diagnosed. I was on the 1P36 website, found you, decided to email you. And so you do have a lot of people in that network. Sometimes people spend a lot of time saying, well, should we interact with other units, or should we try to build kind of centers around bigger cities? And so one of the things that we've seen that has been helpful for some of the organizations I work with is they have local chapters that are very powerful and really do a lot of work in a local area. I don't know if that exists really for 1P36 or not. But basically people step up and say, I want to do this. And they say, I want to do it for Houston. And then they say, I'm going to run this. And they'll actually run underneath the umbrella of a national organization, a local chapter, and then we send our kids to that local chapter because that's where they can easily integrate. I don't know if something like that would be of interest in doing for 1P36, but diaphragmatic hernia is 1 out of every 2,500 to 1,000, or 1 in 2,500 to 1 in 5,000, somewhere in there. It's about the same as 1P36. And so if you look at the numbers are similar. They may have just slightly more kids that are affected than you are, but they tend to be, again, always in a group that they're always diagnosed very early. But anyway, that'd be something to think about.
We have time for maybe a couple more questions, and then we'll need to transition.
Now I'm trying to think what it was. My son's on seizure meds, but they haven't actually shown up on the EKG or EGG or whatever it's called. He's had too many tests, I can't keep him straight. They haven't showed up on the 24-hour video one or the normal ones that they've done in like 15 minutes, but they've never done longer ones. Should I be pushing for like the longer, like the 3-day ones that people have been having, or should I just be let the doctors like keep him on the meds? Because I don't like the fact, I know he's probably having seizures based on what I've seen and everybody else has seen. And he actually was diagnosed by the ER doctor, but not when it came to the genetical doctor, the developmental ped. They have not actually recorded it as diagnosed seizures because it has not showed up on the testing. So do you think that I should push for longer video EEG, or is there other tests that they can do to find out if it's seizures or what?
So that's hard to answer, because if somebody saw something, so say the ER doc saw something that is very typical for a seizure, even if the EEG is normal, if he's having more events like that, he should be on treatment. And the monitoring for the success should be decreasing the number of events. You don't need a longer EEG, especially if it's a seizure that doesn't show up very well on EEG. On the other hand, if nobody is convinced that that the movements that you are seeing are seizures, there are other kinds of movement disorders, and the treatments would be a little bit different. So what you need more than anything else is to work with a neurologist who will pay attention to what you think, pay attention to your child, and thoughtfully approach the problem. And whether you need a specific test or not is not something that we can answer based on interactions here. Does that make sense? So that's part of the nature of seizure disorders, is that you have to adjust the medicines periodically. The children grow, their brains change as they get older, and that changes the amount of predisposition to seizures, which means the medications that you were previously using may or may not continue to be effective. So you may need to adjust doses. You may need to change medications. And in some cases, you're able to wean down the medications or even eliminate them, depending on how things change with time. So you need to have a neurologist and a pediatrician and other specialists as needed who can monitor how things are changing over time and make the adjustments that are needed for your child, and that has to be individualized based on how things are going over the past several months to a year.
My question is more so, my daughter, when she was smaller, she was really thin, but she always had a good appetite. She would even get seen by Failure to Thrive because she wouldn't gain weight. When she turned, so she always had a good appetite. When she turned 7, they removed her tonsils and her adenoids, and then shortly after that, I seen her start gaining weight. I did go to the San Antonio conference, and I seen that a lot of our older 1P36ers, are more prone to like obesity and like started gaining weight and stuff like that. My question is there any kind of linkage with Willie-Prater syndrome and 1P36 that you know of, or how can we do to kind of help this?
So Prader-Willi is a specific diagnosis that is on a different chromosome and has a different way that it manifests. The thing that is the same is the kids that have Prader-Willi, they have this very unique pattern where at the beginning they have failure to thrive. Often they need tube feeding as a child, and then all of a sudden they just ramp up and they gain weight astronomically. The reason why they begin to gain weight is because they can begin to eat first, but also they don't burn calories like a normal child does. And so even if you have them on a normal diet, they still gain weight because their metabolism is lower. Whenever you have a child that's overweight, you're hitting the same problem. It's a balance between how many calories are burned versus how many calories are consumed. And so is the problem the same? Yes. Is the underlying diagnosis the same? No. But you're thinking about the same kind of interventions. It's a balance again between what you're feeding and what the energy is being expended. that's why we're saying when a nutritionist can also be helpful. And sometimes we actually see patterns where we feed children less than we would expect to feed a normal child, because we can see that there's actually causing damage instead of doing good as far as growing.
Maybe last one here, and then we'll transition. Sorry.
Can I just add something to that point from some of the kids in UK and Ireland? It's the same issue that, as you articulated, early years, not much feeding, but then they gain weight. But part of the problem is it's not just they don't burn the calories. Part of the problem seems to be that they don't have an off switch, so they obsess about food, and they don't have the full up switch. Is that something you've seen?
Yes. And so, it's a difficult combination because you have decreased baseline calorie expenditure, and that's part of having low muscle tone. You have normal amount of appetite, or sometimes even increased amount of appetite, with the failure of the normal off switch, and that's not a good combination, because you want more food but you but you need less food. That is a huge that's almost the defining characteristic of Prader-Willi syndrome. It's not as well studied, so we don't know how often that occurs in 1P36, but it does appear to be a component in at least some of the kids, and that's something that we need to identify better mechanisms. It would be really interesting if we understood the physiology of 1P36 and Prader-Willi to see if there's any interaction between those pathways that are abnormal, but that will require us to first figure out what those pathways are.
Okay, it's always fun to have the question and answer part, but we'll kind of transition. We'll give like a 5-minute break, and then we'll move on to our next speaker. Thank you again for you guys coming and giving us your expertise and being willing to be here. I know everybody really appreciates it, and so do I. Thank you.